before we start talking about how to treat the injury, what exactly are we talking about? This picture here is a cadaver picture of a knee. This is the articular cartilage, which you've heard a lot of lectures about. And the anterior cruciate ligament is a ligament in the center of the knee that starts on the medial side of the lateral femoral condyle and attaches into the top of the tibia. But when you look more closely at the anatomy, you actually could see there's what we call two bundles. So if you think of it like crossing your fingers, there's one bundle which is called the anterior medial bundle, which attaches proximal and posterior, and then there's another bundle called the posterior lateral bundle. And over the last 6 to 8 years, that's become a lot more important in terms of how we treat and operate on ACLs. When you look closely, these pictures, the one on the left is a knee in flexion, and the anterior medial bundle becomes tight in flexion, whereas the posterior lateral bundle is more relaxed. And then in extension, the posterior lateral bundle is tight, whereas the anterior medial bundle is more relaxed. And that has a significance in terms of athletic performance and stability. So what does the ACL do? It acts to resist anterior translation of your tibia, your shin bone coming forward on the femur, and that's mostly provided by what we call the anterior medial bundle. And then it also prevents rotation of the tibia on the femur, which is what mostly the posterior lateral bundle does. And it also helps provide stability in side-to-side difference, or what we call varus valgus stability. So why are we talking about ACLs? It seems that every day, week, whether it's in the NFL, NBA, or at the professional level, you hear of some high-profile athlete that tears his ACL. But also, if you have kids or if you're involved in high school sports or college sports, it just seems that every time you turn or look, someone's tearing their ACL, and it seems that it's happening more and more frequently. So there's a reason for that. The ACL is the second most common injured ligament in the knee behind what's called your medial collateral ligament. It estimates to occur in 1 in 3,000 people in the United States, resulting in about 100,000 reconstructions a year, and it's the sixth most common orthopedic procedure performed in the United States. Also, since the late 70s, when females athletes have become participating more and more in high school and school sports, we've seen an explosion of female ACL tears, almost to the order of 9 to 1. There was a study that looked at it at the collegiate level, and female college basketball players were 3.5 times more likely to tear their ACLs than their male counterparts, and in soccer it was 2.67 times, which is significant. The most common people that tear their ACLs still are the recreational skiers. So how does it happen? Typically, you think of an ACL injury as a violent injury, and while it is a violent, devastating injury to the athlete, 70% of the injuries are what we call non-contact, meaning they didn't get hit. They just landed as they're trying to decelerate, and typically they try and change directions abruptly, and their knee pops or buckles on them. And so this sequence of events here shows a basketball player landing, and you could see her knee buckling in and then twisting on itself. What causes an ACL tear? It's generally thought that it's mostly based on the position of your body when you land. Okay, so this picture here on the left shows a basketball player landing with her hips straight, her knees straight, her torso leaning back. She's landing on the ball. She's not on the balls of her feet. She's landing flat-footed, and this puts your ACL at risk. So you could imagine this athlete stopping, landing, and trying to pivot versus this same athlete landing in a more athletic position with her hips and knees bent. She's on the toes of her feet, and this minimizes the risk. So it's thought that the way you land is significantly puts your ACL at risk. The question is, why do some people land in more athletic positions than others? And there's been a lot of research over the last decade to try and elucidate what we could do to prevent ACL tears, and if there's a reason why, or is it just bad luck? One thought is that there's a muscle imbalance. So if you think of your leg, you have your quadriceps muscle, which is your thigh muscle in the front. You have your hamstring muscles, which are the muscles in the back, and those all attach into the knee and are very powerful muscles that allow flexion and extension. And if you have poor hamstring strength, that will pull your knee back when you flex it. And if it's poor, you could have a quadricep dominant leg, and that puts your leg at risk when you land. So one thought is by strengthening muscles preemptively, so with a lot of these speed agility classes that our young athletes are doing, that could help not only improve their performance but help prevent ACL tears. There are also anatomic factors that have been studied, which we obviously can't change, but women in particular generally have wider pelvises, which is a generalization, but is for the most part true, and that puts forces around their knee at different positions than someone with a more narrow pelvis. There's also been studies that have looked at what's called the intercondylar notch. So these pictures here that you're looking at, this is the femur bone. Okay, this is the inside part of the knee, the outside part. This is where your kneecap meets the femur bone, so the kneecap's above you. And this is called the intercondylar notch, where the ACL lives. So you could see this picture on the left has a much narrower notch than the picture on the right. And so there's a thought that if you have a narrow notch, when you land and twist, that this ACL is more likely to be torn because it has a smaller place to live. Obviously, we can't change your anatomy, but it's one thing to consider in terms of why ACL tears. The other factors that have been looked at is the environmental factors, such as the playing surface or the types of shoes that the athletes are wearing. And so as we've moved to more of these synthetic surfaces, or sometimes athletes will try and use longer cleats to give them better traction pivoting, that there's thoughts that that has been why we see more ACL tears today than we did 20 years ago. But again, that's not proven. The final factor that's been looked at, again, to try and elucidate why women are tearing their ACLs more than men or boys, is hormonal. So there have been studies that have shown that there are estrogen receptors on the ACL, and we also know that during the menstrual cycle, your estrogen levels vary, and as you have higher estrogen levels, that can loosen the ligaments. So there's been some theories that maybe there's a higher incidence of ACL tears in the female athlete at different periods during the menstrual cycle, but the studies have been very inconsistent and non-conclusive. So what happens when the athlete tears their ACL? Okay, again, typically it's a very violent, noticeable injury. They're down on the ground, they're holding their knee, they're writhing in pain. Classically, they'll describe that they felt a buckling, popping sensation, and usually they're carted off the field or taken off the field, and by the time they end up in the doctor's office or my office, they have a big swollen knee. 70% of athletes that present with a swollen knee have an ACL tear without ever putting your hands on them or getting an MRI. But typically, they have a big, painful, swollen knee. When you tear your ACL, there's a ligament, there's an artery in the ACL, so when it tears, it bleeds, so that's why you get a big, swollen knee. And also, when your knee buckles, the bones literally bang into each other, so you typically get bone bruising. On exam in the office, we try and get a ligament exam to try and rule out other ligament injuries, but also with your hands, you can get a good sense of whether the ACL is torn. Sometimes acutely that can be difficult because the patient will be guarding and in pain, but most of the time you'll know before you get any further imaging that the ACL is torn or have a high degree of suspicion. Most of the time we will get an MRI, and the picture on the left, this is looking at your knee from the side, so this is the femur bone, this is the tibia or your shin bone, here's your patella or kneecap, and then this is where the ACL should be, and you can see all this white is fluid, and the ACL is very amorphous and not a discrete ligament, which it would normally look like, and so that's what an ACL tear looks like. And then the picture on the right shows bruising in the bone. On the femur, the white is the bruising, and on the top of the tibia is bruising as well. The white here is the fluid or blood that you typically see clinically on the patient. So this situation will resolve with time. So typically the athlete very, very early on is in a lot of pain. They have swelling, but with time, rest, the swelling will go down, the bone bruising will go away, and they'll start to feel better. But without an ACL, they're at high risk for recurrent instability of their knee. So the goals of ACL reconstruction are to provide a stable and pain-free knee under physiologic or athletic conditions. We hope to get the athlete return to their previous level of function as quickly as possible. We want to help prevent future injury to the meniscus or cartilage, and ideally to try and prevent future degenerative arthritis. So are we successful? Success is all in the eyes of the beholder. So typically this is a young person's injury, but as we become more and more active and stay more and more active as we get older, we're doing ACL reconstructions in people through their 40s, 50s, and even occasionally in their 60s for the high-demand recreational athlete. In terms of success, the risk of re-tearing your ACL after an ACL reconstruction is 6%. So as a surgeon, 6% I don't love, but 94% success is good. The range in the literature is from 3 to 30%. Once you've been identified with an ACL tear, you actually have a 12% risk statistically of tearing your opposite side. In terms of getting athletes back to sports, that's really how we define success, and 50% of them return to competing at the same level, whereas 80% return to a competitive level. So again, we get most people back to playing sports, but the real issue is whether we can get them back playing at a college, professional, or high school level. So what is the problem? Why can't we get everyone back to their normal levels, and why can't we get 100% success as opposed to a 6% failure rate? We've looked at a lot of different factors throughout the years. Over the last 6 to 7 years, there's been a lot of focus on the anatomy and how we actually perform the ACL reconstruction. And specifically, we've looked at the tunnel position because historically, when we've done the ACLs, we drill a hole through the tibia into the top of the tibia, and then we would drill a hole into the femur, and this would be what your ACL would look like. However, and I'll show this in other slides, we've learned that the anatomy of the ACL is that it attaches more lower on the femur, and we've theorized that the reason why patients don't do well when they return to sports is we're giving them something to give stability from the tibia moving forward on the femur, but we haven't fixed the rotatory stability. So when they go back to cutting type sports, that's why there's a higher risk of their knee buckling again or giving out, and or why they can't go back to playing at the high level. We've looked at how we fix the ACL in terms of screws, buttons, whatnot. Graft choices basically come in two flavors. You could take tissue from the patient themselves, that's called an autograft, and there's different types of tissue we could take. And then we've also can use cadaver tissue, and there's been a lot of focus on how we treat the cadavers or try and sterilize them to prevent infection, and that's been looked at and changed throughout the years to try and make that more appropriate, because the problem with sterilizing the ACL grafts in a cadaver is that you can weaken them, so sterilized grafts have a higher risk of failure. So in my practice, I've moved away from using sterilized grafts, but they're sterile but not irradiated. We've looked at the rehab program. Most athletes want to be better yesterday, and so we have to balance doing the appropriate thing, because you can't rush biology, and getting them back as quickly as possible, but also doing it in an appropriate manner. The hardest thing is setting up patients' expectations, because there are patient factors that are outside of your control as a surgeon, in the sense that if you just tear your ACL versus tearing your ACL, your meniscus, the collateral ligaments, and or injure your cartilage, those two patients are not the same. So not all ACL tears are the same, and it's hard when you're comparing yourself to a buddy of yours who tore their ACL, but you didn't have the same exact injuries. It's hard to compare apples to apples. So the principles of ACL reconstruction, it's a same-day procedure. You go home the same day. Most of us in the community have moved to what we call an anatomic approach. So again, we used to make an incision here. We still do make an incision here, but drill through the tibia. You could only make a hole in the femur based on where your hole in the tibia was, and that sort of limited where you could put what we call the femoral tunnel, whereas now I make a separate low incision so I can independently make the femoral tunnel wherever I think the normal anatomy is, to try and recreate the anatomy. And this has been shown to restore normal knee mechanics better. It improves rotatory stability. So these pictures here show what I'm talking about, in the sense the picture on the left is where I would put my normal femoral tunnel, and this is where the normal ACL attaches, whereas the picture on the right is an arthroscopic picture showing an instrument going through the tibia, and this is where I would have to put the femoral tunnel, and this is where historically it would go, and you could see the dramatic difference of this is where the normal ACL attaches versus where we historically would have put an ACL. And so we believe that by doing it in a more anatomic fashion, just like a fracture, when you heal a fracture, you try and heal it anatomically. Now we're trying to recreate the ACL anatomy back to its normal anatomy. So post-operatively, after the surgery, patients are typically in a brace. They're given crutches. We try and ice them immediately to try and help decrease the swelling. In terms of rehab principles, it's somewhat controversial in the sense that there's no one way of skinning the cat, and what I do in my practice may be slightly different than what someone else does. And there's no real right answer, but the principles are all the same. So immediately post-operatively, we're trying to minimize the swelling. We want to start getting you to fire your quadriceps, because the quadriceps atrophies very quickly. We want you to start lifting your leg, what's called straight leg raising, lifting it straight up off the table. And we encourage heel slides, where you're trying to start to bend your knee more like his left knee is over here. But this is just a picture of a brace. After a week or two, when the swelling is minimized, we try and increase your range of motion to 90 degrees, and we start what's called closed kinetic chain activities with a therapist. By 4 weeks, we try and improve your range of motion from full extension to 120 degrees. We start increasing your strength, get you back cardiovascularly, usually on a bike or an elliptical machine. If aquatic therapy is available to you with your physical therapy center, then that's something else that can be very beneficial. Up to 3 months, we're increasing your flexibility. We're going to continue strengthening you, trying to work on neuromuscular control, which is typically something that you had a problem with and maybe why you tore your ACL in the first place. So we want to rebalance you. And usually at 3 months, we let you start running. In terms of return to play, which is a conversation you always have, particularly with the young athlete, because if they get hurt in their junior year of high school, that could be something that has an impact on them for scholarships. And so obviously the kids want to get back as quickly as possible, but we also want to do it in a safe and reasonable manner. So the goal is to increase the strength, power, and endurance. We want to increase running and cutting to meet the demands of the individual sport, increase their cardiovascular demands. There was a study that showed that athletes that returned to play in less than 7 months had a 15% risk of re-tearing their reconstructed ACL, versus if they waited till after 7 months, it was 5%. So I generally get most of the athletes back in 6 to 9 months, but again, it depends on how you're doing. We want your strength to be equal to the opposite side. The other factor is biology, because you can't rush biology. Once you put an ACL in, whether you're 14, 15, 20, or a professional athlete, you can't rush the biology. And that's why most NFL players, it takes a good 9 to 12 months before they're back playing football. But yet somehow at the high school level, they want to get back in 4 months, and that's something we struggle with weekly. But after you put in an ACL, you're basically taking a tendon and trying to make it a ligament. So there's a revascularization process at 8 to 10 weeks. There's cellular proliferation, and the graft is firmly attached to the bone, typically by 8 weeks. And it can take 1 year for the graft to become mature histologically. Obviously, in a perfect world, we try and prevent all ACL tears from ever happening, and there's been a lot of focus on ACL prevention, and the question is, can we prevent it? The focus of ACL prevention is on biomechanical factors, really focusing on neuromuscular control in terms of your hip abductors, your core, your quadriceps, and the studies have shown that there can be a dramatic improvement. Generally, if you look at the picture here, this is a female soccer player landing. Her knees are buckled, her knees bent inwards, and that's what we call an ACL at-risk athlete. So we want to help them land on the balls of their feet, the soft landing, toe-to-heel rocking motion, whereas the picture on the right is a much more athletic landing position. Bert Mandelbaum out in California has a website called aclprevent.com, which I highly recommend you go to. He's shown in his studies over an 80% reduction over 2 years in girls playing soccer. There's been other studies that looked at balance drills, jumping drills, so we can prevent them. The problem is convincing trainers, parents, coaches to try and implement these programs before they tear the ACL. Most of us don't like to do anything until there's a problem, whereas it's hard for me to convince people to do things preemptively. This is an example of Bert Mandelbaum's program, easily done. It's a 15-minute warm-up that you could add mostly to soccer training, and it's something I encourage you to look at on his website called ACL Prevent. So in summary, ACL tears continue to increase. Not all ACL tears are the same. In my opinion, anatomic reconstruction is important to giving the athlete the best chance to return to play at their previous level. We need to be realistic, have appropriate expectations, so it's important to understand that not all ACL tears are the same. And in a perfect world, we try and prevent the ACL tears, and it can be done, not 100%, but significantly improved. Again, I encourage you to look at the website aclprevent.com.